4, 3, 2, 1. We are now live.
Warm welcome to the 50th webinar of Pediatric Orthopedic Society of India. This is a special webinar for all of us because we started our journey almost before 2 years. On the 24th of March 2020, we did our first webinar. And in a span of almost 2 years, today we are on a special occasion where we are celebrating the 50th webinar. Today, this webinar is very special to us because the speaker for today's webinar is also very special. We are very fortunate to have Professor Reinhold Ganz with us. If I introduce him, probably it will be an insult to Professor Reinhold Ganz, but I would just like to tell you briefly about his major contribution in the field of orthopedics. Yesterday, I was trying to look for the number of papers. He has more than 130 papers in the English speaking publications. And I'm sure the equal number will be for the other languages. His major contribution is periacetabular osteotomy, the concept about the vascular anatomy of the hip, which leads to a new procedure called a safe surgical dislocation. Again, that facilitated a new or like revival of a procedure, which is a modified Dunn's osteotomy. Again, his major contribution is a concept that's FAI. Again, relative neck lengthening, head reduction surgery, capsular interposition arthroplasty are his major contribution. So in short, we can always say that hip preservation surgery is equal to Professor Ganz. On this special occasion, we are really fortunate to have experts panelists from 5 well-known pediatric orthopedic society. From POSNA, we have a Michael Millis. Mike Millis is special for this occasion because Professor Ganz could not visit India, but since 2010, Mike Millis with Young Joachim, with Dr. Risha Madhuri, Dr. Prasad, they are spreading the work of Professor Ganz in India. We welcome Professor Antonio Andreacchio, who is the president of EPOS, to this special webinar. Again, we have Ed Bache, who is representing BSCOS, because from tomorrow, the BSCOS annual meeting is going to be there. But Ed Bache was kind enough to accept our invitation and has decided to participate in this webinar. The president of Canadian Pediatric Orthopedic Group, Dr. Debra Bartley, is also with us. And the Secretary General of Egyptian Orthopaedic Association, Hassan El-Barbary, is also going to participate as an expert. In addition to that, we have Dr. Sunil from Sri Lanka, a very senior pediatric orthopedic surgeon of Sri Lanka, also as a guest. The outline of the program for initial 40 to 50 minutes, we will like to hear the lifetime work of Professor Ganz. After that, we will have an interaction with Professor Ganz, and then we will take the audience question. If you have any question, you can either text message or WhatsApp to Dr. Sandeep Patwardhan, the Secretary of POSI, on 98230-63989. I repeat, 98230-63989. Before I hand over to Professor Ganz, I just would like to mention about the upcoming events. On the 7th April, we have a joint webinar with BSCOS, and in that we are going to discuss about the fractures of lateral condyle in children. In this journey of 2 years and the 50 webinars, a lot of people have helped us. I would like to say thank you to all of them. I cannot tell you the name of all the faculty because we have more than 80 international faculty and almost 70 national faculty who participated in these webinars. The viewers across the globe, we are thankful to them for taking interest and for viewing our webinars. These webinars are uploaded on the POSI website and anyone can see it free anytime from the POSI website. That's www.posi.in. I'm also thankful to POSI members for their constant encouragement and their suggestions for the newer topics and recommending the newer faculty. The executive committee has always supported us in such endeavors. I would also like to say a special thanks to two persons. They are conducting our web committee, Dr. Taral Nagda and Dr. Ishwar. They are very helpful to us in propagating these information on the social media. And last but not the least, the team of OrthoTV, Dr. Ashok, Shyam, Dr. Neeraj, Bijlani, and all others, they have been great help in these webinars. So with that, I hand over to Professor Ganz for his lecture. Over to you, sir.
Thank you, Darren. Thank you for this kind introduction. Hello, everybody. Greetings from Switzerland. Let me say, I gave what I'm doing. Okay, here we are. Now, let me see whether I can do it as it should be done. Yes, here we are. My presentation will cover a period of about 30 years or even more for preservation of the native hip. Of course, it's mainly surgery in children, but there are also some adults, I would say up to the age of 30, patients are treated with these kind of procedures. What I will present here is a kind of summary, and if you are interested in more details, I can think that you may catch some of the aspects and will continue to be interested. But don't go home and do this kind of surgery just after this presentation. The title also bespeaks all the difficulties we had in the past. Until the orthopedic community or establishment, I must say, started to accept the concepts, and this is a process which is still not completed. Becoming chairman of the orthopedic department in Bern in 1980, I had to make a decision how to continue with hip surgery. Either to follow the mainstream of joint replacement as the favorite answer for hip problems, or to invest in the young patient's hip and look for new solutions of joint preservation before substantial cartilage degeneration has taken place. Now, Bern had already a history of osteotomies of the hip. My teacher, the osteotomies of the hip joint, and we did quite a few proximal femoral osteotomies, but the results did not always meet the expectations because most indications were hips with already advanced osteoarthritis. Now, this is one of my cases where I still think even today that the indication was correct. This young chap had a femoral neck fracture from skiing, and this is some years later with an obliterated joint space on the outside, as you can see here. And in a deduction, the hip opens, the joint space opens, as you can see here. So since this patient already had a relief of pain in this position, we thought a valgus osteotomy could be helpful. This is what we did. You can see here the lateral cortex, and this is the other lateral cortex. So that's about 30 degrees of valgus or abduction osteotomy. Now, this hip lasted for about 10 years before he redeveloped again pain. And finally, he ended up with a prosthesis. This is some years after with a very good outcome. Now, this is the same patient. Now he's 84 years old. This is 33 years after total hip replacement. He is still very active and enjoys long skiing trips. Now, we knew that if we want to achieve something new, we have to look for the vascular supply to the hip joint. We also could see that available approaches were not very tissue friendly. And one example is the well-known Coker-Langenbeck approach, which splits the gluteus maximus and cuts all external rotators. They are resutured, but this never really survived the next day. Now, if we look to the vascular anatomy in textbooks, then these descriptions all come from anatomists, and they have no other interest than accuracy. So they are not surgeons. Surgeons' interest in anatomy is driven by the desire to approach an area without interfering with novel structures. So consequently, we started our own studies of the vascular anatomy with the objective to eventually improve approaches or procedures allowing powerful correction without collateral damage. Now, our first project was related to acetabular reorientation. We were not satisfied by the available procedures because they were interfering with the acetabular blood supply. Some had limited corrections or needed several approaches. There was no or limited access to the joint. The fragment positioning was difficult and not very well defined. Fragment fixation was so la la. Some needed a plaster, and very important, some of them did a narrowing of the birth canal, and we have to remember that most of these patients are young females in the reproductive age. Now, the requirements list for a new pelvic osteotomy, we would do all osteotomies from the pelvic inside, an area which is nearly free of vascular suppliers to the acetabular bone. We were aiming for a high potential of correction. We wanted to have intra-articular access without restrictions. One approach, easy fragment fixation, and no interference with the birth canal. Now, what you see on the upper left is the sequence of the osteotomy, which was developed with a multitude of dissections of cadavers. It was about a year until we had the final solution, which was accepted by all the participants. What you see, one is the partial osteotomy of the ischium from anterior. 2 is the complete osteotomy of the pubis. 3 is the supraacetabular osteotomy from inside. 4 is the retroacetabular osteotomy from inside. And 5 is the connection of the number 1 osteotomy so that the fragment is completely free. On this slide, you see the posterior column remains intact. This is good for stability of the hemipelvis. It protects the sciatic nerve, and it excludes all ligaments from the sacrum to the pelvis. So the correction of the fragment is relatively free. Now, this slide from a cadaver dissection shows, I hope you can see, it's not a very easy. You can see the vascular circuit all around with a number of anastomosis. So whenever you cut somewhere into the circuit, it will be replaced by other vessels. We also did intraoperative laser Doppler flowmetry, and this test showed a temporary decrease during the dislocation of the fragment, but normalization of the perfusions thereafter. Now, this is part of our dissection work. It's the hip from outside. You see the displacement of the acetabular fragment. Here the gaps everywhere, here the gaps. And you see that these vessels from the superior gluteal artery and from the inferior gluteal artery remain intact. So with this kind of osteotomy, one could preserve the entire or the majority of the the blood suppliers to the joint, which allowed intraoperative access to the inside of the joint. Now, we did the cadaver dissections during the year of '83. In Switzerland, at that time, you could not do such dissections. So we had to go to Paris to the Anatomie Saint-Père. This is part of the University Descartes. The fragment vascularity was mainly done by Tosun Nguyen, who was an orthopedic professor, but worked mainly in anatomy with students. Martin Beck was one of my co-workers. The osteotomy steps, this was a back and forth between me and Jeff Mast, who was much more involved than myself because I had to run the department and he was a guest and had all the time to go to Paris. The first live operation was in March '84 after we had completed 25 cadaver test runs. It took us 4 hours to do PAO, periacetabular osteotomy, and femoral osteotomy. After 3 days, we observed posterior subluxation, no, 3 months, posterior subluxation, which had to be treated with a posterior shelf. Now here you see the case. This is a PFFD. The arrows point towards the posterior border of the acetabulum. This line here. So this is a complete retroversion. Today we know this is nearly to be seen in all PFFD hips. At that time, we did not know about this. This is the post-op X-ray. Again, we left the retroversion of the acetabulum untreated, and this was the reason why the femoral head dislocated posteriorly. Here you see the plate which was fixing the posterior shelf. This is 32 years after surgery when she started to have pain again and finally got a total hip replacement. Now these figures come from the first 75 cases, a group of absolutely inhomogeneous cases. There were everything, pertes, dysplasia, patients, they had several osteotomies. So it was very, very little homogeneous material. After 10 years, 88% were still okay. After 20 years, only 60%. And after 30 years, only 30% were still working well. Now, today, we can do better. Now, this is one more actual case, a 20-year-old female with more pain on the right side. You can see here the arrow points to a number of cysts in the acetabulum, and the expert knows under such a line of cysts, there is no good cartilage at all. So this is a very a borderline situation. If the patient would be 30 or 35, we would even say it's too late. Here you see the other problem. She has a fatigue fracture of the acetabular rim. Also on this side, it's not so easy to see, but here you see the non-union, and this is a fatigue fracture. We see this occasionally. What made this case a little bit more difficult was the high coxa. You see the growth plate is even negatively inclined, so it was a head in the neck situation. Now, this is the situation after bilateral femoral varus osteotomy. We did an intertrochanteric osteotomy because it's easier than a neck osteotomy, and when it's bilateral, the indication is okay. Here you see the correction, which is here a little bit excessive. This would be called to be correct. Here you see the situation after metal removal, and the real thing which is interested, here you see before surgery, the non-union, the dislocation of the fragment, which now is, the fragment is consolidated, and we have a perfect acetabular line. The cysts, which were here not very well visible, but here they are about to disappear. This is a patient with Charcot-Marie-Tooth, 14-year-old. He had a varus osteotomy before on the left side. This is the side we did first. You see the excessive valgus. We did not have a plate to fix this correctly, so we had to pre-bend a little bit this plate in order to get the amount of valgus necessary. You can see the amount of correction possible. This is the teardrop area, which was down here, as you can see, and just to show the amount of correction possible. This is 11 and 13 years after surgery. We know from several cases, the results in Charcot-Marie-Tooth do not last as long as doing the same operation in standard deviation. Today, PAO is our most reliable joint preserving procedure, and it has reached rather high international acceptance. The features are intact fragment perfusion, even with large corrections, and extended capsulotomy. Single approach, it's a modified Smith-Peterson approach. It is a polygonal juxta-articular osteotomy, which allows relatively high inherent stability before you fix it. So you need very little extra fixation. Normally, we use 3 screws. The posterior column is intact. We can achieve a high potential of spatial correction, which is not limited. Especially the rotation of the fragment at the end of the procedure is the critical point. And the dimension of the true pelvis is preserved even when performed bilaterally. Our second project was to look for a safe technique of surgical hip dislocation. We had several cases where we did attempts to debride the joint from anterior and posterior, knowing full well that the femoral necrosis when joint is dislocated. And there are necrosis described for the anterior and for the posterior approach. So we were in a little problem situation. I was lucky that my daughter, that's the girl here, was finishing medical school, and she needed to do a thesis. And then I allowed her to go to Paris again to do some cadaver dissections. They came back after 3 months with fantastic pictures, as you can see here. And we said, if this all is true, we can do a surgical dislocation of the hip without risking necrosis. So in a way, these two girls was the startup group of all what we did later on. Now, Mota Sakalwo from Tehran, who was a fellow and still is a fellow, he comes again and again. He did a number of dissections. The important aspect, here you see the hip from posterior. This is the obturator externus muscle and tendon. And here you see the deep branch of the medial femoral circumflex artery passing posterior to the tendon, diving down anteriorly under the triceps coxae, which is this, into the joint. Now, what he also found is that there is an anastomosis always, but sometimes the anastomosis from the inferior gluteal artery, the arrow points to this, is bigger than the deep branch of the medial femoral circumflex artery. Here you see it again, and this is a straight way from the anastomosis into the retinacular vessels at the neck. So there are cases, about 20%, where the anastomosis is the bigger vessel than the deep branch. Emmanuel Gauthier, another resident of our department at that time, he did further studies. He just showed that, or how much one can dislocate the femoral head out of the socket. This is the socket. And you see the dislocation is limited by the tendon of the obturator externus tendon. Now, this tendon, where is my arrow? This tendon protects the deep branch of the medial femoral circumflex artery. So, we have an impact of the externus tendon. This vessel, this circulation is protected. This is our first case, or one of our first cases, with multiple chondromas in the joint, operated several times. This is after surgery with a redress of the subluxation and clinical improvement. It's about 10 years that after surgery when she needed a total hip replacement. Now, this is a summary picture of the procedure, first denounced as a criminal method, and we had a difficult time at the beginning. Surgical dislocation of the hip became a widely used approach. Today, it is the workhorse for a multitude of procedures around the hip. The third project was femoral acetabular impingement. It was not a project. It was initially an accidental observation while testing on the open joint how range of motion would correspond with clinically measured range of motion. Now, what we saw again and again was damage of the acetabular cartilage, which could be attributed to even small femoral and or acetabular deformities. It could be observed how such a joint misfit creates a destructive force during motion. The multitude of similar observations allowed finally to formulate and validate the impingement concept during the years of 96 to 99. Below you see the subgroups. The pincer impingement is an impact between a femoral neck or head-neck junction to the border of the acetabulum. So it's a rim problem, while the cam impingement is when the head or the head-neck junction intrudes inside the joint, and then the cartilage in this area will be ripped off. Now, here you see pincer impingement in a case of a deep socket, which means global overcoverage. So can you imagine if this motion is produced with high speed, it may destroy the cartilage. Here you see the same joint, but the impingement posteriorly in full extension and external rotation. And you'll see how the joint looks, or the rim looks. Here you see inside the acetabulum, and you see on the medial side, the medial border, you see a typical ganglion formation. And we see this now again and again in the MRI, and we know this is pincer impingement. That's the ganglion. Now let's go to the cam impingement. It is much less dramatic. You just see a little bit of motion of the acetabular rim here, but it's not much. Very little motion. Now the head is dislocated. And you can see it's not round over here. It's, you know, it's the radius of the head is from here to here increasing. And that's inside. You see an outside-in abrasion of the cartilage. Now, this looks much less dramatic, but it is much more destructive. This kind of impingement we see in men, while the former one is more frequent in women. So, FAI is a complex problem with intra and or extra articular contribution. 70% of the involved hips suffer from more than one component. Impingement may create joint subluxation, which probably is more important than the impingement itself. Slip capital femoral epiphysis is a prototype of FAI, and we will hear this or see this a little bit later. Now, FAI is not new. This is the femur of or the 1,000-year-old femur of a Viking sailor lost in action near the South England coast. And you see the extension of the femoral head, which increases the radius easily from here to here, and which is responsible for the jamming. Now, Joe Müller has found a 5,000-year-old specimen with nearly the same deformation. There are early pointers. They didn't know what they saw, but they saw there is some problem. And Poirier, a French anatomist, he called this empreinte iliaque. Today we call it subspinous impingement. Lane from England, in his book, also describes what's called today subspinous impingement. And very interesting, at the time, Kaiser, a German surgeon, he looked for hips with osteoarthritis, and he found that abnormal version of the acetabulum is frequently combined with it. Today we know retroversion is one aspect which can create FAI. Now, there is also a number of surgeons, they did some treatment. Mikulich was probably the first who described in 1903 how to resect a bump in a morphology which today would be called a skiffy. Whitman did the same. Vulpius described Mikulich's operations. Miss Peterson is normally referred to in the United States for his successful acetabuloplasty. Hyman had done Vulpius in SCFI. Carlius did the same. Now, what we see here is the drawing for Mikulich in this kind of resection, the dotted line here, in a deformity, which is probably an old skiffy. Now, I must put this a little bit down. Sorry, cannot read it. I cannot. When we presented our material the first time in 1999, people were laughing and said, if this would exist, I would have seen it. Now we are in 2021, and you see the exponential evolution of the literature. Today, FAI has cut out the primary osteoarthritis of the hip from the etiological catalog, and it makes a living for a number of arthroscopists. Fourth project was the extended retinacular flap. It is a further development of Dunn's localized dissection. What he did not do, which is essential to create an extended flap, is to cut down the stable part of the trochanter after trochanteric osteotomy down to the neck, and to do a dislocation of the joint. Today, it is the workhorse for some intercapsular procedures: subcapital realignment, relative lengthening, true femoral neck osteotomy, and femoral head reduction. Here is again dissections from Morteza Calho. On this side, you see the medial branch of the medial femoral circumflex artery feeding the medial portion of the femoral head. And here we see the deep branch of the medial femoral circumflex artery with the arborization along the posterolateral neck into the head. Now, with the extended retinacular flap, which is shown here, you can take this vessels from the neck. You can approach the neck 360 degrees without interfering with the blood supply with the head. And you see the distance here to here. That's the area where you can work, and having such a long flap, any extra distension or even rupture of the retinaculum is very difficult. And this is the original drawing from Dunn, and you see this is a very short distance where he did his dissection, and to say he did it without taking down the greater trochanter, and he did it without dislocating the joint. Relative lengthening of the femoral neck. This is a 30-year-old female. She had a varus osteotomy bilaterally for pain, but the pain came from a deep socket. So we had to take down the greater trochanter, and this is the right hip, which you see here. This is, again, that's why we call it relative. In fact, we do not lengthen the neck, but we take down the greater trochanter, and this increases the freedom for motion. Now, this is, let me see, this is just a video, intro video, which shows the dissection of the flap in a slip situation. We look, the head is dislocated, as you can see. This is the growth plate of the trochanter, which is taken down. There are some small vessels to the bone of the greater trochanter. So down, and we will see later when these pieces of bone are taken off, that we have a long flap down to the lesser trochanter. This is a oops maneuver. Yeah, again. So these pieces are taken away. Now you can see on to the posterior neck. One has to be careful not to touch the the insertion of flap on the femoral head. So this is enough. We can see around the neck. Now the head is turned externally, and now we do the same on the inner side. So we have retractors around the neck. And now we can remove the epiphysis, which still keeps the blood supply, because this is the one flap and the other one is now disappearing. So we see at the end onto the, voila. This is the metaphysis. An important aspect, which we do not see very well here, is bone formation down here. Now it's removed. This is always present, even in so-called acute slips. We do not shorten the neck, we just remove residuals of the growth plate. So it's not a shortening. Shortening is dangerous because then the flap becomes too long. Now we also take out the cartilage remainders from the epiphysis. You see, I hold with my fingers, I hold the epiphysis. You see, it's bleeding out of the head. The head is reduced. That's the most difficult part, to know what is the optimal position of the head in terms of rotation and varus valgus. First pin through the fovea, and then the other pins come from the other side. This is a case which shows why we call it a prototype of inflection. You see metaphysis here with the arrow. Inflection, this part is entering into the joint and is producing cartilage damage. This is the callus I was talking about, and you see here the callus is removed. If we would leave the callus, the retinaculum would have to be deviated around and would be stretched. Michael Leunig had difficulties to publish this paper on 15 cases. 2 times it was rejected, but finally Acta Orthopaedica Scandinavia took it, and they awarded it as one of the 10 most cited articles in 2003. Now, we had a series of 126 cases, and of course, we looked always in the joint, we looked for damage, and we looked for other things. What we saw is that there is a poor correlation between all clinical stability measurements and intraoperative stability. A SCFI leads to FIA. 86% had signs of damage and 74% had substantial damage. Retinacular rupture, which is rare, but when it happens, but also time to surgery increase the risks for disturbed epiphyseal perfusion. In our series of proven dislocated hips, 27 out of 35 were perfused at capsulotomy, but 31 out of 35 after realignment. So it's important to do this quickly. 32, there's one case who had a second surgery where we saw, it's perfused. Posterior callus is frequently present in disconnected hips, even when reported as acute and without prodromes. If not resected, posterior callus will lead to stretch the retinaculum, and this may stop the perfusion. Now, this is a case with an amputated leg on the other side. You see his extreme dislocation of the femoral head. And this is 7 years after. He doesn't even use a prosthesis on this side, but loads everything here on this side. Now, this is a very important study showing that intact retinacular blood supply from the lateral retinaculum perfuses the entire epiphysis, while intact medial vessel and retinaculum perfuses the medial half of the femoral head. This means we can resect the middle portion without interfering with the blood supply on this and on the other side. So the vascular dual circuit allows segmental intracapital resection. This is one case. The surgery, you can see this is the healthy part. These hips are better than hips without a healthy lateral pillar. This is again the protrusion of the lateral part. You see the trochanteric osteotomy is already performed. Cartilage often looks quite nice, but underneath there is the necrosis. It makes sense to remove the round ligament. Here you can, this is the necrotic portion. The cartilage is not as good as it looked before. It's more soft. Again, the greater trochanter is taken down, similar to what you saw before. Now we see to the posterior neck. At the beginning, we did the sizing of the femoral head by eyeballing. I was never quite sure whether I do too much or not enough. So this middle section will be removed. Now this portion, this is the medial portion. This remains stable. This is the lateral portion, which will be mobilized. The intermediate portion will be taken out, and this portion will be reduced against the medial stable portion. You see, this is now mobile, or it will be mobile in a second. This is the necrosis here. Now the mobile segment is reduced against the stable one. And then fixed with 2 screws. I can go ahead. This is a more recent case. You see, this is the healthy part. The head is extruded, flat upper surface. This is 2 months after surgery when she started walking again and loading the hip. We now combine periacetabular osteotomy because it restabilizes the smaller head in the socket, which has some adaptive changes due to the bigger size of the head. This is an older case, 15-year result, in a time when we did not routinely do periacetabular osteotomy, a difficult situation with no vital lateral pillar. He is now ready for a PAO. Now today we do computer simulation of best segment size and cut direction, which makes life much easier. Here you see this cutting template placed, fixed on the head, and here you see the oscillating saw cutting into the head according to the computer simulation. This is the segment which has to be taken out. A final head size on here. You see here, this is the osteotomy. Now, we have about close to 90 cases now. We could call it a direct approach to severe femoral head deformation with hinged abduction. Best age is between 9 to 15. Best condition is a vital lateral column. Additional PRO improves stability of the new head. Computer simulation and cutting devices facilitate precise technical execution. So far, the results are surprisingly good and clearly advantage over salvage procedures. We have now 10-year results, and they confirm this statement. So the extended retinacular flap has opened a no-go zone of the intracapsular hip space, powerful osteotomies with few adverse side corrections. As an outlook, the presented procedures are certainly more laborious than pinning in situ, but they are learnable. A fellowship is the best way to become familiar. Cadaver dissections are very helpful. Concentrating the caseload will shorten the learning process. Thank you very much for listening.
Excellent work, excellent. Like in just 45 minutes, you summarize your journey of 30 years. And like we all were flabbergasted, like how much one person can do and how many new ideas one can give to the world. Superb.
Yeah.
So without wasting much time, I would request Mike Millis to have his comments on Professor Ganz' work.
Thank you, Darren. May I share my screen?
Yeah, please, sir.
First, it's a great pleasure, an honor, and frightening to follow my colleague, mentor, and friend, Reinhold Ganz. A terrific life and lots of lessons to be learned. So this is a brief discussion about my thoughts regarding Professor Ganz and his contributions. The themes that we are discussing this evening include the hip for sure. They also include POSI, and I would say bravo, Darren and Indian colleagues, for the webinars and how you have made a difficult situation into a very positive one. I think Professor Ganz's presentation also outlines the great help that international cooperation has brought, because this is indeed a brilliant career, a brilliant man, a genius, who has lectured to us just now. But he has also admitted that international cooperation, for example, working with Morteza Kalor and Jeff Mast, has enabled some insights that otherwise might not have been possible. In 1986, Mike Millis first met Reinhold Ganz. PAO was not yet in the literature. Surgical dislocations were being talked about, but indeed, as Reinhold has said, maybe had not actually been done yet. FAI was certainly not yet described, but the concept was in Ganz's head. So this is a very young Mike Millis, a young Reinhold Ganz, and Steve Murphy at the time of one of our Harvard osteotomy courses in Boston. And my head was swimming with new concepts, and indeed my head is still swimming with concepts that Reinhold outlines for me daily still. This is 2022. Hip preservation surgery has clearly flourished. There are major advances directed by Reinhold Ganz from Bern, and indeed from a lot of centers that have been influenced by Bern. History is important to know where we came from. And Professor Ganz has already shown us pictures of Maurice Mueller, his predecessor in Bern. I'll also credit Renato Bombelli, Robert Salter, Sugioka, Dietrich Tonis, and one of my major mentors, Heinz Wagner, and William Harris, who also has pioneered the concept that there is probably no such thing as primary osteoarthritis, or if there is, it's very rare. Innovation in science can be viewed upon as having an episodic model. And Thomas Kuhn has written about this in his interesting books in several editions, The Structure of Scientific Revolutions. There are periods of so-called normal science, where there is conceptual continuity with cumulative progress, interspersed with periods of so-called revolutionary science, where there are new paradigms, breaking old rules, establishing new rules, disruptive innovation. We today have heard about many examples of disruptive innovation. So what lessons have we learned? Can we learn, and will we still learn from Reinhold Ganz? He is a brave, courageous explorer. Years ago, when he began this journey into hip preservation surgery, he was almost alone. Clearly, since then, he has demonstrated he is not only a brave, courageous explorer, he is a master surgeon. He is an anatomist. He is a physiologist. He is an outstanding mentor and teacher. He is a historian, and indeed, he is truly a philosopher. How has Professor Ganz changed us? Well, I've looked for direction to a famous Indian-American surgeon in Harvard who has helped me understand Professor Ganz's contributions and how he has inspired us. Professor Gawande has written several interesting books, including the Checklist Manifesto, Complications, another book called On Being Mortal, and another interesting book called Better, subtitled A Surgeon's Notes on Improvement. So Gawande's suggestions on how to become a positive deviant, indeed, Reinhold Ganz is a role model for the so-called positive deviant, how to make yourself better, how to make progress. Number one, ask an unscripted question. Yes, Professor Ganz has done this for decades, asked many important questions, and then looked for answers. Number two, don't complain. As Professor Ganz has mentioned, early on, his concept, his ideas were viewed as very radical, and indeed, he discussed surgical dislocation as a so-called criminal procedure. Professor Ganz has proceeded despite criticism. Number three, Gawande says, count something. Professor Ganz, throughout his career, has carefully documented his findings. Very important. Number four, Gawande says, write something. Professor Ganz has written multiple classic papers that will live on and live on and live on. Number five, Gawande says, change. Professor Ganz is still innovating. It's very clear. He is a very young, very vibrant, very innovative thinker. He is a role model for us all, and he continues to inspire me daily. Thank you, Professor Ganz.
Thank you, Mike, for giving us the overview of his contribution to the field. Before I ask Tony to give his comments on his work, I would like to ask Professor Ganz. I'm sure that during your journey, you must have faced a lot of criticism. A lot of colleagues must have told you that you have very crazy ideas. How do you respond to such criticism? or how do you face it?
Maybe I didn't answer. I don't think that I really went into discussions with somebody who called this crazy. Normally, this is rarely a face-to-face situation. Normally, you hear that this guy and this guy at a meeting comment your material. So that's where I know the criticism of others. The personal criticism face-to-face is really rare. It's mainly a question then.
Okay, thank you. Now I request Professor Tony to share his words about like how he see his Professor Ganz contribution and how you are going to implement all these ideas in Europe.
So thank you so much for your outstanding speech. And of course, I really impressed when I assisted to the surgery. I guess, but that's my personal opinion, this kind of surgery is not so reproducible. And so that's important to have a specific surgeon and very specialized hospital where to perform this kind of surgery. Otherwise, the complication could be increased, and the ideas and the concept is absolutely correct, but if in the wrong hands, the outcomes could be worse. Then that's my personal idea. So of course, like everything, when you see some surgery in the end of the maestro, is fantastic, and it seems very easy. But you have to take, you have to recognize that is not so easy, and you need a learning curve in order to be absolutely correct in not only into the indication, because the indication maybe is the easy part of this kind of surgery, but in order to perfectly perform every step of this surgery and to preserve the perfusion of the femoral head. I have just only two or three, just not provocative, but a little bit clarification in order to the people. And I mean, the one question is, does it worth to verify during the surgery the perfusion of the femoral head after you have to perform the osteotomy of the neck, just before to keep up the femoral head in the new position? And then my first question. The second one, which is the role of non-weight bearing in the post-op period in order to preserve vascularization and perfusion, because in my little experience, I found some worst patient outcome in patient who didn't allow or didn't follow exactly the prescription, and they have a weight bearing very precocious way, and in this way the femoral head collapsed. And the third and last, my question is, is it really important to perform this kind of surgery even in the acute SCIFI, or we in this kind of patient, we can wait at the beginning and then we can go to the OR emergency. We try to reduce this kind of the SCIFI and then to fix in situ, and after that we consider in the second period the possibility to have this kind of surgery. Thank you.
Yeah, Professor Ganz, would you like to answer the three questions of Tony?
Yeah, the first question was about whether it's necessary to always control the perfusions with laser Doppler fluorometry or another technique. One must see that at the beginning we had to do this. We had to prove that we are on the safe side. Today we don't use it every time, but what we do occasionally when bleeding out of the fragments is not absolutely clear, we do some drill holes in the head in order to be sure that there is enough perfusion. Sometimes it's the position of the head which prevents visible perfusion. So we have to reduce the head into the socket, wait a few minutes, and then look again. So but these are the cases where, let's say, the perfusion is questionable. So we don't do it generally with laser Doppler fluorometry. This is too expensive, too laborious. But in case we are not quite sure, we do 2 millimeter drill holes, normally in the fovea or in an area of the head where the minimal cartilage damage is not important. Now, the second was about post-op. I cannot recall a situation where I finally had to accuse loading for a necrosis or collapse. I think of course, we do not allow full weight bearing immediately, but these young hips consolidate very quickly after 6 weeks. The stability is sufficient to keep this minimal weight of the patient. They have 20 kilos, 25 or 30. That's not much. I think this is, but I would never contribute it to a collapse, not contribute to too much weight bearing. I don't see this as a realistic relation.
Thank you.
The third one, what was the third?
It's acute skiffy.
Yeah, it's the acute skiffy where I become nervous, where I say, now it's Saturday afternoon, let's do it. We cannot wait until Monday. And our cases, our observations during surgery, that there is no, there are several cases, I mentioned it, where there was no perfusion with laser Doppler fluorometry, no perfusion at the moment of capsulotomy. So you could say this is the moment, the situation where you say, I did pinning in situ and now we are safe until next Monday. No. If it's dislocated, it can be that this is the cause of stop of perfusion. So I want to be sure that perfusion is re-established. So I can only do this by doing surgery immediately. We have 3 necrosis, 3, in this material of 35 cases. 1 had a ruptured retinaculum. This is, you can do nothing. We had 2 where the time of between, let's say, accident and surgery was just too much, too long. So for me, it's absolutely clear. Acute slips, so-called acute slips, that's the indication for immediate emergency intervention.
Thank you.
Yeah, thank you. Sandeep, yeah, your question, and then we will come to Ed for his comments.
Thank you, Professor Ganz, for a brilliant talk. My question is that you made it sound so easy. And as Tony has pointed out, a lot of centers have complained around the world that the techniques are not reproducible. and they have restricted this surgery to be done only by few. And what would your answer be to this criticism as to how much cases would be a learning curve for a young surgeon who is now excited after listening to your talk and suddenly tomorrow wants to start doing this? Because there is a real risk of creating surgical terrorists after you see something so brilliant.
Yeah, that's why I said at the beginning, don't go home and do it. You should learn it. So the first step is you have to understand vascular anatomy. Not as it's written in the books. You have to really understand. You have to be sure that you can go around these vessels easily because you know where they are. That's different to the standard opinion. I know anatomy. People don't know anatomy, they know approaches. This is not anatomy, not at all. So to understand vascular anatomy is a process. You cannot learn this from books. You have to go into the cadaver lab. So nobody should go and do it tomorrow. Yeah, and when somebody says it is not reproducible, my answer is, then you did a different thing. Where did you learn it? No, anatomy makes no compromises, but it's always very constant. And if you follow exactly the rules, you will not fail. This is for sure. So somebody says, I did it exactly how he said. He didn't do it. He just said he did it, but he didn't do it. For sure.
Okay.
Yeah. Before
All
like
people they came to us, all people they came to us for a certain period. They were able to do it.
What is the minimum time period of training and how many cases would you say is a learning curve?
It depends from where you start. If you have experience with pelvic surgery as a trauma surgeon, if you have some idea how a hand surgeon, I think this is one of the best preconditions. You need maybe 6 weeks or 3 months, but if you are a real beginner, it takes longer. The best would be 1 year. But it's learnable.
Yeah.
Yes.
Ed, what would you like to ask Professor? I'm sure that you must have a lot of query about the learning curve and how to learn it better.
Yeah. Learning curve is, you asking me?
Yes.
Okay. A learning curve is something which is not well fixed. You know, my learning curve with periacetabular osteotomy was about 50 cases. And I know this because that's about the time when I did not, how to say, do the surgery in my head the evening before, when I forgot to do this. So I was familiar. I was not nervous anymore. 50 cases myself. After 1 year, plus minus 1 year of cadaver work with vascularity, discussions, how to cut, what is the risk, all this. So anybody who comes from medical school and just is wants to do it, is enthusiastic, he needs much longer, for sure. So learning curve and learning curve, two different things.
Okay, thank you. Ed, can we have your comment?
Yes, thank you. Firstly, that was really a masterful presentation, Professor Ganz, on the subject of hip preservation surgery, and I guess it's a testament really that now, certainly when we look at periacetabular osteotomies for hip dysplasia, it's now such a recognized procedure, and even our arthroplasty colleagues now are coming to us and asking us if these patients are suitable for hip preservation surgery. So I thank you for that, and I look forward to the 20 and 30 year follow-up of some of the other procedures, the head reduction osteotomies and some of the newer procedures. There are many questions I would like to ask, but for the sake of time and to give everybody else a chance, I'll just stick to one. And this is a problem for those of us that sort of do a lot of pediatric hip surgery, and we are following our patients up. Do you think there's a role, and if so, in the asymptomatic adolescent patient with residual dysplasia? Should we be operating on the asymptomatic 14, 15, 16-year-olds with residual dysplasia?
Yeah, I think first we have to discuss what is asymptomatic. Is asymptomatic has no pain, or is also asymptomatic that he is limping? Is asymptomatic when he has no internal rotation and all is external rotation? So what is symptomatic? I would not do surgery on any dysplasia of a 16-year-old, but there are dysplasias I would not wait until he has pain, because when he has pain, he has already cartilage damage. So if you repair your car, you repair it before it stops functioning. So we should do the same. We should do surgery before the damage is visible for everybody.
Good.
you.
You
So, yes
answer
and
it in a
no.
very different analogy, and like, Ed, would you like to have a counter question on this?
Yeah, well, I'm not sure so much whether it's a question. I mean, I guess we have patients that we know who've got significant dysplasia, you know, lateral center edge angles down at 10 degrees, and yet when we know they're going to become symptomatic in their late teens and 20s, but these are still big operations that carry a degree of risk, and these are patients who are at important stages of their life. And I have to say, I find it very difficult to suggest to these patients that we should be putting them through major operations when they have no symptoms. Although, of course, we counsel them very carefully that as soon as they do have any pain or limitation in their activities, then we need to see them as soon as possible.
Yeah,
I guess that's a comment.
That's a good compromise. But, you know, I feel my duty more as an advocate of the hip, not so much as an advocate of the patient.
That's nice. I like that.
Yes, Mike first and then Sandeep. And after that, to Debra. Yeah, Mike, please.
Reinhold, I'm glad you told us your great concept that you're the advocate for the hip. I've heard you say that before to patients when they weren't necessarily advocating well for their own hips. I've also heard you say that, and you've said it in another way tonight, pain is not the only important symptom.
Yes.
And that's absolutely correct. And I think that some of these patients, way before they have pain, their hips are clearly not functioning normally.
Yes.
The other thing we can do these days is there are high quality MRIs. And if we can't really understand what's going on, we have also often done baseline MRIs. And then after a year or two, you do another high quality MRI. And if you see any change in a negative way, then I think that's an even stronger indication for surgery.
Yes, Sandeep.
Yeah, so I'm just asking a question which Sunil actually has put up in the chat box. If there is established avascular necrosis post-procedure or for whatever reason, do you have a solution for that?
It depends very much whether this is a total head involvement, it depends, or a segmental necrosis, and then it depends where the segment is. Then our question is, how old is the patient? If he is 16, I would not give up. If he is 35, I would say, and the necrosis is, let's say, where I'm not sure whether I really can help him, I would say, I tell him I have a possibility, but the chance is not high that this hip will last more than several months or 2 years. And then it is a decision between both of us, patient and me, to decide to do it or to wait for prosthesis. It's
So
difficult
if-
to say. This is changes from case to case.
Yes. What would be your preferred method? Would it be arthrodiastasis, drilling, injection of bisphosphonate? How would you approach a young child, say 10, 12, 13 years old?
Yeah, you cannot. I cannot give a useful answer, you see, because there are so many aspects and factors involved. Also, we've never talked about patients' expectations. You know, when he says, I want to go back to play soccer, and I say, listen, even if the hip would be, would have a good result, I would not consider that soccer is a good idea. And so there are several aspects. You see me hesitating to give you a right answer because any answer theoretically is not a good answer. It's
Okay. So
one has
I
to
guess
discuss it case by case.
Yes. So probably we say we individualize the treatment based
Absolutely.
on surgeon's experience with the
Yes.
technique and the patient's
Yes.
expectations out of the problem.
Of course, yeah.
Okay.
Yeah, Debra, please.
Good morning, good afternoon, and good evening from
Hello.
around the world. It's a privilege to represent my Canadian colleagues here. Professor Ganz, I learned something from you every time I hear you speak, and I hope our learning is not over. I hope you have lots more to teach us. I've gathered questions from around the country. A lot of them have already been answered, but I will build on the idea of experience and large volumes of cases. And so I guess our question to you is, if you were going to build the best model for delivery of hip preservation in Canada, so realizing we are a large country and we are very spread out as far as a smaller population, should we be building centers, maybe a few across the country, where we really build hip preservation surgeries and bring our patients there? And if so, who do you think is best to deliver this care? So in Canada right now, probably hip preservation surgery is delivered by pediatric orthopedic surgeons, sports orthopedic surgeons, and arthroplasty surgeons. And so do we all have a role to play, or should we be training a cradle to grave hip surgeon?
You know, everybody in this group could be a candidate to say something, but also everybody could be not qualified to say something. So it depends on the personal desire. Would he just be on top of a group to be a leader, or is he interested in the subject, in the hip itself? What kind of education he has? Was he a foot surgeon yesterday, and now he wants to be the leader of a new center of preservation of the hip? difficult to say. I have been in Canada, but I don't know the situations, the conditions, how to do this. Generally speaking, yes, centers are necessary. And parents come to the centers, whatever distance it is. So the size of the country is not important. I have some experience in Italy. I went there after retirement for about 15 years, from Torino to Venice, and patients travel. It's amazing, you know, they just follow you. So distances is not important. I would say if you are really convinced that you have to do this and you are able to do it, and you find people they are willing to help and pulling in the same direction of the string, yes, do it. And Canada has place for several centers, I would say. Yeah, but do it.
Thank you.
May I request Dr. Hassan to ask his question or his comments?
Thank you very much, dear Professor, and it's a pleasure to be with all of you. I have to ask Professor Ganz 2 questions. First, after the surgery on the 2nd or 3rd day, do we routinely have to search for AVN, or if the head is viable intraoperative, then it's sure that it will be viable?
Yes.
I mean, how early do we have to search for AVN postoperatively?
If you have done the tests intraoperatively,
yes,
even till the latest, you know, one final possibility to kill the blood supply is when you refix the greater trochanter, because you can squeeze the retinaculum with the greater trochanter if you don't fix it properly. If you don't control this, everything was fine till this moment, you know, so who knows? But these are the surprises that 3 months and has signs of necrosis. Yeah, I have seen such cases. But if you are sure that everything went well and there was bleeding during surgery till the latest possible moment, you don't need to check.
No need to check on the 2nd day?
No, the 2nd day does not show anything.
Yeah.
You cannot see a stop of perfusion the 2nd day. It's the MRI doesn't show. There's no way to see it clearly.
What about the bone scan?
Yes, because some literature reports that we should do a bone scan on the 2nd day, and if we find that there is evidence of AVN, we should go fast to arthrodiastasis to protect the head from collapse.
I don't do this because all the data you get from bone scan, from MRI the 2nd day are questionable. It's not 100% security that this is vital or necrotic.
Okay,
so 2nd day is not a moment. The 2nd day is not a time to decide upon weight bearing or not, because the patient who has, let's say, a neck osteotomy, he will not, if this child is obeying, he may walk on crutches. You cannot bind it in the bed for how long? 6 months or? So this is all, for me, wishy-washy. So if I have no doubt that the perfusion is okay, I'm not looking for this possibility. I trust myself.
Okay, I want to ask another question concerning the femoroacetabular impingement. do you think it's better to operate even in the asymptomatic or the contralateral side of an asymptomatic case?
Is it a boy?
The
Is the patient a
asymptomatic,
boy?
yeah, a boy.
A boy. What
It's
he's
more
doing? Soccer player, ice hockey player. What he's doing?
Whatsoever. He's a boy about.
No, this is important what I tell him or what
Yeah.
I decide to do.
If he's not a soccer player, should I wait to be symptomatic?
If he is not interested in sports at all, I would probably wait and see, but I would call him back say a year or 6 months, depends on the situation. It depends on how much pain he has. Is this pain really related to the impingement? You know, all these questions have to be answered before. And then you decide, okay, come back in 6 months or come back in 1 year and we check again. So, but if the deformity is clear,
yeah,
and if this boy is very, very rough and do everything, goes up the trees and falls down and does this, I would, yeah, it could be a situation that I say, let's do it now. But you cannot generalize this.
Yeah.
Okay, colleagues, now we are like coming into the webinar. So I request Dr. Sandeep to have a vote of thanks. Over to you, Sandeep. Thank you.
Thank you. Thank you, Dhiren bhai. It has really been a memorable 90 minutes. When I was a child, I was fascinated when Star Wars was released. I thought nothing can beat a movie like Star Wars. But I think Professor Ganz' 45-minute movie really has blown everybody's mind away and opened up their eyes to a new world of, I think this is the beginning of a new era of hip preservation that is coming up, and we are fortunate to be part of this wonderful exposition of his talk. And I would like to thank Professor Ganz for sparing time and delivering one of the most memorable orations that most of us would have heard, with examples, videos, and his candid answers to the tough questions that were asked of him. And I think I can take away a message that, one, question what is the norm and try to find an answer. And second, customize your treatment depending on your population and your patient and their requirements and your experience. Also, I would like to thank Dr. Millis for so succinctly putting up the crux of Dr. Ganz' talks and beautifully contributing to this meeting. Thank you, Dr. Mike Millis. You've always been a friend of POSI and very generous with your comments and praise for and love for India. I thank Professor Antonia Andreacchio from EPOS for contributing to this meeting, Dr. Ed Bache for the perspective from the British side, and Dr. Hassan for your pointed questions regarding distraction, as well as Dr. Debra for really bringing up an important question where a country should now decide how to handle hip preservation. Would it be training surgeons or bringing up centers and allowing their youngsters who are now really going to take over this mantle from Professor Ganz with this new concept? So with those final few words, thank you, ladies and gentlemen, and have a good day ahead. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you.
Bye-bye.
Bye.
Ashok, can you stop the recording? Yes, now we are not live, so we can now chit chat.